really something that we encounter, something that we encounter a lot of in Liberia, and not just Liberia, but also the whole region is severe malaria. So I wanted to try to go over a few things a little. I mean, some of these things you'll already be aware of, but I want to try to tie some of the pathophysiology of what's happening with a child with severe malaria into some of the that we do. So as a bit of an introduction, we all know this is very common. In Harper, you're going to see a lot of this as well, especially as we soon be heading into the rainy season. I know it's February, but we'll soon be going into the rains. We have a lot of children coming with severe malaria. Really, what I want to try and do is get a little bit more of a clear definition of what we mean when we're talking about severe malaria, and try to sort of look at our monitoring, our how we're responding to things that are changing in the child. As children with severe malaria, their vital signs, other parts of their condition can change quite quickly, and it's important that we are active and we're responding to those, and we understand what those subtle changes can actually mean. So why is it important? Well, actually, severe malaria, this is something that you can treat this. Children do get better. If we get in early enough, we get our treatment going quickly enough, we can do better. And the main sort of aspect to doing this well is actually the supportive care around it. So we're going to talk a little bit about things like urine output. We're going to talk about fluid monitoring, why that's important. And one of the things I would say, really in anything pediatric, that to make it work well is kind of attention to detail. So by that, I don't mean ordering lots and lots of tests or getting stuck in sort of minutiae of development or whatever. I'm talking about details like, okay, yesterday the child's respiratory rate was 32. Today it's gone up to 40. Now we need to think about why. Okay, yesterday we had urine output of maybe 200 mils. Today we're down to 5 mils. Something is going on in this child that we need to respond to. So that's why you have your kind of close monitoring that we need to be doing with these children. And then also thinking about resource management. You know, we have limited supplies all over the world of our test units. We don't want to be giving our test unit just as soon as a child tests positive. It shouldn't be straight to IV our test unit. So we need to have a way of figuring out who really needs to use this precious medicine, who needs the most close monitoring, who needs to be on bed, who needs to be going home, and just to have a good way of understanding that well. So what I want to try and say is some of the things which would make me think that the child has severe malaria. So some of these things are obvious. I'll tell you what, let me take this slide away. I'll ask you guys some questions. What would make you think a child had severe malaria opposed to just normal, uncomplicated malaria? Shout out some answers.
Yeah, temperature above 30 degrees.
Okay.
Just sort of fever.
Okay, did you say prostration?
Yeah, prostration.
Very good.
Having just being weak, not taking anything, that's vomiting everything up.
Okay, unable to take medicine. Yeah, that's very important. Good.
And the fever above probably 38 degrees to 40.
Okay, now a fever is interesting because a fever just tells you that the child is fighting something off. So a fever on its own is not necessarily something that tells you that you've got more severe malaria. I mean, it can tell you, it suggests you've got a high parasite count, but on its own, I'm not too concerned about a fever. Any other signs or things that you might see? Okay, well, I'll talk us through a few things. So you're correct. Prostration is an obvious one. So really a child who just can't walk or sit without any support, I mean, that child is going to need to be admitted because they are at risk of getting very sick quickly. Any child who's had really more or equal than 2 convulsions in 24 hours, that's interesting. Children who get a high fever then have a convulsion and then are entirely well and running around the place afterwards. That's not really too much of a concern. That's a febrile convulsion. Whereas if you have a child who's having recurrent convulsions or their conscious level is starting to drop, that's more of a concern. Similarly, a child who's having a hypoglycemic episode, anyone in shock, anyone who's anemic, and then also increased work of breathing where pneumonia. Now, something I want to touch on, moving a little bit into the pathophysiology. Why is it that children with malaria have increased work of breathing? What is happening inside the child? Can you tell me, like, what physiological changes are giving a child respiratory distress if they have malaria? Anyone tell me some answers? What do you think? Everyone's very quiet. Just say something, anything as to why do you think children...
It's because of lactic acidosis. When they're having malaria, there's a lot of hemolysis. With the anemia, you have accumulation of lactate. So they need to remove carbon dioxide through increased breathing. So they tend to have a respiratory distress because they want to eliminate the carbon dioxide from the system.
Fantastic, very good. So any child, often you may see a child with severe malaria, you'll see their respiratory rate has gone up, but then you listen to their chest and you don't hear any signs and you think, this is very strange. But it's because basically they are overcompensating for what's called a metabolic acidosis. So the lactate has piled up inside their bloodstream and they're essentially trying to blow it off. So that is one reason. Other reasons, anemia will make a child have increased work of breathing. Thirdly, if they have a pneumonia associated, and the other one, it's quite a late sign really, is if the child has gone into pulmonary edema, really that's due to sort of later cardiac. Whoa, I'm getting old. Could you just move that again? There we are, thank you. So those are the reasons. I'm going to talk about that more in a second, but what I want to say is just things that are not cerebral malaria. So when somebody just says, oh, the child has 4+, to me, 4+ is not very exciting because a high parasite count, yes, that could be indicative of severe malaria, but the plus kind of scheme, 1+, 2+, 3+4 is very, very inaccurate. So I don't put too much focus on whether it's 1+ or 4+. Similarly, neonates with a fever, I often go on about this. It's very unlikely that malaria is the driving force here. I would not get too excited. I would manage as a neonatal sepsis till proven otherwise. Similarly, children who are running around the place, mobilizing, or a child who's just had 1 or 2 episodes of vomiting, but they're still eating and drinking. Those kind of children, they're not really severe malaria. So what I would do if a child doesn't have severe malaria, and you would monitor them for an hour or 2, make sure they can tolerate the oral medicine, then you send them home and you give them good worsening advice. So you say, okay, if your child starts vomiting, anything else happens, bring them straight back. And, I think PIH have this down in Harper, but also at ELWA. Under 5 clinic is very accessible. It's very easy for them to get in again. So that's not a problem. Brief bit of pathophysiology. I'm sure you guys probably went through this in med school, but I just want to go through it again so that we're all clear. You can see the life cycle here. You've got your mosquito there. The sporozoites are going into your liver. And so that's why you have your sort of initial 5 to 7 days in asymptomatic stage where you've got basically your the parasites are sitting inside your hepatocytes. and they come out, they're merozoites, they go inside your red cells, they become ring trophozoites, this is falciparum, and then eventually you get, it's called a schizont, and then that kind of breaks apart, and they go on into other red cells, and some of those red cells will then go on to form gametocytes, which are then picked up and taken away in the mosquito. So that's what's going on. Now, it's important to get an understanding of that, because that tells you why certain things are happening. So if you have quite a high parasite count and you have lots and lots of ring trophozoites, and that's seen under a microscope, you know that within a few hours or days, you're going to probably notice quite a substantial drop in hemoglobin, and also quite a high level of lactate, because all of a sudden your red cells are going to be all lysing. That basically sets off an endothelial cascade, so you start getting high fevers. That's when the children feel most unwell. And that's also when lactic acid starts to build up as well at the same time. And so if you can get a more accurate parasite count, that is potentially quite helpful. That may tell you what's going to happen. But this also helps you because it tells you basically what to do in terms of, say you have a child who comes to the ER, you see on day one, their hemoglobin is, say, at 6.2, but you see a high parasite count, you know that you need to monitor that hemoglobin, because by the next day, it may be 5.1, then it may be 4.7, you know, it could be going down. So that's why that attention to detail, that monitoring of that hemoglobin is actually very, very important. Now, cerebral malaria, I wanted to talk about a bit as well. And this is I like this diagram because it's very simple. And this just kind of shows you a little bit about what's happening. And you can see in normal time, your blood-brain barrier doesn't really let very much across. But what happens as somebody gets quite a high parasite count is you get a lot of your red cells are sort of full of parasites. They start to create little blockages in the capillaries in someone's brain. Then you end up with an endothelial sort of damage to the lining of the capillaries. That's what's going on there. And then gradually you get all these sort of pro-inflammatory cytokines that start to then spill over into the brain tissue. So you can see what then happens is some of the brain cells actually start to die. They get they go through a process of apoptosis. And there's a little diagram at the bottom. You can see an apoptotic neuron. That's what's happened there. So it's essentially what's happening there is you've got a high parasite count, you've got blockage in the cerebral capillaries, and then you've got cytokine-related damage to the brain. So that's why you can end up with all the various problems of cerebral malaria, which include the comatose state, the convulsions, potentially brain damage later down the line. All of those things are really, really quite serious. So that's something to just watch very, very closely. If you have a child with altered level of consciousness, this is essentially what's happening on a kind of pathophysiological basis. Just going to try to, oh, there we are. Good. So as with everything in pediatrics, so that you kind of know where you are with your child and you're able to give good handovers, receive good handovers, come up with a very coherent management plan, your ABC approach is really, really important. So why would a child with malaria have an airway problem? Can anyone help me? Anyone think, like, if you have, say you have cerebral malaria, why are we concerned about a child's airway in cerebral malaria? Okay, so if you think about it, if you have a child with cerebral malaria and they're in a coma, you need to be thinking about the airway, because they're at risk of they're at risk of aspirations, they're at risk of their tongue flopping backwards and damaging and basically obstructing the airway. They're at risk of convulsing. Any child who has a convulsion, that's an airway risk. So you just need to be mindful of that and think about your positioning. So you'll be making sure the child's in the left lateral position. And it's tempting to say, oh, we're going to leave that to the nurses. But actually, if you're doing your rounds, you see a child in a coma and you see the child's just lying, you know, kind of prostrate on their back, or the mum is sitting the child up and keeps trying to feed the child when they're in a coma. That's potentially really serious. So it's really important to get the child into the right position. And then you move on to B, which is breathing. We talked about this already. These are your sort of reason respiratory distress. And I would say as well, if you have a child who's come through the ER, maybe they've been unwell for quite a long time, and the child's been vomiting and they've been in a coma. Remember, they could well have an aspiration pneumonia as well. So it's always worth listening to the chest, seeing if you're hearing coarse crackles, usually be on the right side. The other thing that's worth doing, I mean, I know the HemoQ machines are still hard to come by, but that's the easiest way to get a hemoglobin, is to check, basically use the HemoQ machine. So there is one in Under 5 clinic. It gives you an answer within like 5 seconds. Trying to get one put into the ER still very easy to do that. And then, basically there's also pulmonary edema and metabolic acidosis. Really both of those things we talked on already. So just to say what to do, I mean, positioning is important. If you've got someone in severe respiratory distress, particularly if you're worried about the possibility of edema, 45 degrees is the right position. Oxygen is good, but just be aware that if you've got metabolic acidosis, oxygen isn't necessarily going to reduce the work of breathing, because they're just blowing off that excess CO2. Not really much that you can do. I mean, you put a bit of oxygen up, but you wouldn't necessarily be expecting to see a huge response if there's metabolic acidosis. If I've got a child with breathing difficulties in malaria, I'm always going to cover them with a broad spectrum antibiotic. Ceftriaxone is the right one if I'm concerned about aspiration, and in metronidazole as well. Now, one thing about frusemide, be very, very careful with that in a child with malaria, because be aware that these children may well be in renal failure. So I would always want to see some urine output and be aware that the child at least has urine output before I started frusemide. Be aware, I mean, getting creatinines in children is not very good, because the ones we have are very unreliable, and creatinines in children are not very helpful, because you can be in quite severe renal failure before your creatinine even goes off. So a far more useful test is urine output. And if the mum tells you the child has not passed urine at all for the last 2 days, I would not give frusemide, because that child almost certainly is in renal failure. And if you hit them with a diuretic, it's probably going to get worse. If you're hearing wheeze, salbutamol is good. And what I would say is there's no evidence for steroids, really. There's just no evidence that steroids would actually help the situation at all. Just to give you an x-ray there, the problem is the answers are written on there, but you can see this is a sort of a respiratory distress in the context of malaria. You can see the left base there. There's a little bit of a consolidation there, almost a small effusion, see a bit of a meniscus. And there's sort of patchy consolidation, both lung fields there as well. So really that's very, that's quite a severe sort of respiratory distress there. Moving on to circulation, then we'll stop for any kind of questions. Just be aware, this is probably, in terms of the ABC, it's probably the one that's going to fluctuate most. Be aware that hemoglobins will be on the way down if you've got a high parasite count. Every child with malaria, you need to check for shock. So you need to be checking your 3 signs, your pulse, your CRT, and your cold hands. If you see all 3 signs of shock, then you know 10 mils per kg bolus. You've got 3 goes of those if you need them every 30 minutes. And the important thing is that monitoring. So I would actually get daily hemoglobins. I don't think getting daily CBCs is needed. That doesn't tell you anything, but daily hemoglobins is very, very helpful. And if you've got a hemoglobin less than 5, then you need to do a transfusion. If you've got shock and it's less than 6, you also need to transfuse as well. Now, I know in other talks we talked about maintenance fluids. I'm not going to talk about the calculations for that again, but what I would say is that maintenance fluids probably save more lives than anything else in the hospital, really, because if you don't have reliable maintenance fluids, even if you treat the shock and you treat the anemia, the child is still going to go back into shock. They're still going to go down. So it's really, really important. Use the fluid management sheets, prescribe the fluids, get the nurses to give it really every 3 hours to be checking on it. Just be aware that if you write it as a over 24 hours prescription, it'll get given one time and then you'll have it for the rest of the day. So that's why I get them to do it every 3 hours. It just helps the situation quite a lot, really. And you can see there's obviously just a picture of a child who clearly does need some maintenance. I'm going to stop for a second there for any questions, and then we'll move on to the second half. Any questions on that at all?
I think we can go ahead.
We can go ahead. Okay, good. No worries. If anything else comes, feel free to interrupt or put something in the chat. That's perfectly fine. So just wanted to show you this MRI scan of, just again, moving on to cerebral malaria. You can see the sort of whitish here. That's actually areas of brain tissue that have gone through apoptosis. Essentially, there's not been enough blood for those areas. Some of that's reversible, some of it's not. And I wanted to touch on some of the nursing care guidelines, and this is almost getting into some of the team management, health management stuff, because when you guys finish as residents, you'll be, you may well be the doctor in the entire county. You may be the doctor in, in Ganta, or you may be the doctor in, in Grand Jude. And so you'll be leading your nursing team in situations as well. So just wanted to say a couple of things. With your nurses, it's really important that you, that you direct them, you encourage them in the right ways. So what I would say is this thing about line of sight. So if you have a child who has cerebral malaria and is very sick, you want them within line of sight of the nurse's station, because they're hiding behind walls and, if they're right at the back, they're not going to get seen quickly. So they're not going to be actioned. What's going to happen is they're basically just things they can change. The mum might start feeding them with all sorts of stuff. Things can really change fast. So you need to be making sure that your hospital's set up in a way that the nurses can see those children very easily. And the other thing is the monitoring. So vital signs, in terms of a coma score, GCS isn't really too relevant for children, certainly younger ones. So, very simple AVPU is fine, and also urine output. Now, even if you don't have a catheter, you can look at, well, has the child passed urine? How many wet Pampers have you got? What's happening with that? So this is really important, and we talked about clearing the airway already, and making sure that you're avoiding aspirations. So, child is in a lateral position. And I love NG tubes. I think children with severe malaria who are in comas must have an NG tube. The reason for that is not for feeding. It's initially to aspirate stomach contents. The reason for that is if the stomachs get overfull, they start vomiting, then they're at risk of inhaling the various food contents. And aspiration pneumonias, I don't know if you've ever, you've probably all dealt with people with them. They're very nasty. They're often anaerobic things. Sometimes they get better with metronidazole. Sometimes you find yourself running through every antibiotic, and then they're on like tazocin or something, and they're piperamycin, and they're still not getting better. So the more you can do to prevent aspiration, the better things will be. Other simple things, make sure that they're not lying in wet areas. Make sure your nurses are cleaning things. Sorry, the slide has fallen off the bottom there, but monitoring for signs of raised intracranial pressure. So maybe having a look at pupils. Are they getting dilated? Are they unequal? Occasionally checking a blood pressure is not bad, but other things you'll see is if you want to be really detailed, look at the back of the eyes, you're seeing papilledema. All those things will tell you that the child is actually deteriorating because you've got raised intracranial pressure. So other things to monitor, I mean, you'll know some of this already, but make sure that your fluids are not going too fast or too slow. I mean, it can be a challenge sometimes when you do a ward round. Just got to make sure that your fluids are getting given, especially overnight. If that's not happening, then you know, you need to really push the team there, because there's sometimes, I mean, there's times when I've come in the morning and making rounds, and you'll see the fluid charts, only like half the entries are there. So you realize, oh dear, like a lot of the fluids have not actually been given. So it's really important to document that clearly and say to the nurses, rather than just writing in an order, you need to grab and say to them, look, this child needs, whether it's in 200 mils or 140 mils of DNS every 3 hours, and I'll be checking on it in the morning. That's really, really important. So there we go. Respiratory rate is a very underrated vital sign. You know, I would want someone to have a look at it every 4 hours rather than just sort of 2 or 3 times a day. Certainly, there is actually conflicting guidance as to what is normal and what isn't. But what's important is the trend. I mean, if you have a child with metabolic acidosis, like we were talking about earlier, they come in, their initial respiratory rate is, say it's a 2-year-old, the respiratory rate is 60. And then the next day it's going up to 70, then it's going up to 80. You know that things are not improving, even if your SpO2 is normal. Whereas if you know, okay, the respiratory rate has gone from 60, now it's 52, the next day it's 35, you know that you're seeing success. So those kind of little attentions to detail will tell you what's going on. We talked about AFPU already, but I just wanted to give you a guideline with urine volume. So if you're seeing generally less than 17 mLs per hour in an adult, or 0.3 mils per kg, which is a by far more useful measure in a child. So if you're seeing less than that, that's oliguria, and that means that potentially your child is either in shock or is at risk of going into shock. Certainly they're not perfusing their kidneys the way they need to. So what I would do is, if you have a way to get the amount of urine, say you look at your catheter bag and you realize in 12 hours the child has passed 100 mLs and it's a 20 kg child, if they've only passed 100 mLs in 12 hours, that means per kg they passed, well, they passed 5 mLs, and they're a 20 kg child, 5 into 20, you know, they passed, it's quite a low amount. 5 over 20 would be, it's 0.25, I think. I need to, my maths is a bit shoddy, but you can work it out. So if you look at the amount that they passed in 12 hours or 24 hours, divide it by the number of hours, divide it by the weight. And if it's less than 0.3, then you need to be thinking, is the child in shock? So you do your assessment, your whole cold feet and hands. You may want to give a fluid bolus as well, and another 10 mils per kg and reassess. Now, blood glucose, I think this is something is under-checked. So PEDS ward has its own blood glucose machine now. So there's no excuse for not checking blood glucose. You can really push the nurses on this. And what I would do is I would document and say, check blood sugar every 4 hours while the patient is unconscious. If it's less than 54, then you want to treat that. I mean, there is some evidence to say if it's less than 70, treat it. But certainly less than 54, I would be giving a D10, 5 mils per kg, and it's a stat fast bolus. And then you repeat your RBS 30 minutes later. Now, it's very easy just to treat the sugar and kind of walk away, but you need to be making sure that's being repeated. Make sure that maintenance fluid is going on. All these things need to be happening, really. So good. Other things just to check. I mean, convulsions, just be aware, you've got a bit of a balance in a very sick child between managing the convulsion and not knocking off the respiratory drive. Because if you have a child who's got, say they're in a coma, they've got very severe malaria, and they start convulsing, you need to treat that. You need to be managing that. You just need to be careful because at times, if you give too much diazepam, you can actually cause the respiratory effort to really, really reduce quite dramatically. So generally, the guideline is if you have an actual seizure more than 5 minutes, or if you're seeing 2 smaller seizures within an hour, then you need to treat it. But if I'm just seeing a sort of a bit of decerebrate posturing or decorticate posturing, I'm not going to treat that with diazepam. I'm going to sort of leave that out. I'm looking for a kind of a genuine seizure convulsion event involving either the limbs or the whole body. And then I'm going to treat that. And you've got a second go at that if you need. If it's still going on, your second line, 15 milligrams per kg, and that's over 15 minutes. It's really important. Some of the nurses know how to give it well, some of them don't. It's really important that you document how to give it, because if you just put it inside a normal saline and they just give it over 3 hours, it's not going to work. Or it'll take a very long time to work. So it's very, very important just to make sure that the nurses are taking their time and doing it over 15 minutes. And just things to be aware of, bleeding and hemorrhage, that's a sign of what? Can someone tell me if I've got severe malaria and then I see the child starts bleeding from their nose or their ears or something, what is going on there? What's the process? Okay, so I'm talking about just basically disseminated intravascular coagulation. So, I mean, that's a really late sign. If you're seeing a child with malaria and they start bleeding out, that's almost unsurvivable, because that means that their whole coagulation cascade's been kind of disrupted. We had one child back in November when I was there, a very sad child, was had malaria, seemed to be improving initially, and then overnight started bleeding out from various orifices. That was DIC. It's very hard to get a child back from that. So it's worth just documenting that as well. I mean, someone mentioned temperature. It is important to control temperature because that can cause seizures as well. So if the child is in a coma, remember, you can use rectal paracetamol. Similarly, keeping the child comfortable is good. There's not actually much evidence necessarily that tepid sponging is always a good idea, but if it makes the child comfortable, then that's a good thing, and you're reducing the cerebral irritation. One thing I would say, it's really important to respond to changes that are taking place in a child. So what you don't want to be doing is, and this is why I always push back on this when it's suggested, is when people prescribe artesunates, 0, 12, and 24 hours, and then they write followed by Coartem, followed by something else. And you think, no, actually, what I want to see is somebody has prescribed that, but then they're going to be going back to that child a few hours later to see if there's an improvement or a deterioration, or if they're not themselves going back, they're going to hand over to someone else to see if anything has improved or got better or gone down. And if it has, then you can change and you can respond, because you need to know if your treatment's working. For example, if you give a fluid bolus to treat shock, you need to be circling back to that child and saying, well, has it worked? Do we need another bolus? Or are we actually saying, well, no, it's been successful, we're fine. And just a bit of word on progression. Once your child's starting to wake up, starting to respond, they're maybe starting to sort of kick and move around a bit, and they're responding to voice rather than just pain, then you may want to start nasogastric feeding. Just be aware that if you have a child who's got cerebral malaria, they're in a coma, and they're in a coma for a week or 2 weeks, their nutrition is going to go right down. Their albumin is going to go right down. Everything's going to fall apart. So you need to be thinking about the nutrition, paying attention to your anthropometrics, which we've done that in other classes. Very quick summary of your initial assessment. Documenting things, very important. All of these things should be in your assessment if you're seeing them. So an AFPU, think about consciousness. Are there seizures? Is there any posturing? What's happening with respirations? What's the hemoglobin, pulse rate? Blood pressure is less essential. I'm less concerned about that. If you can do it, it's helpful, but not so much. Are they dehydrated? And then obviously CRT. And if you can get all that into an ABC type format, that's very helpful. And just to say, these are the lab tests that help you. We all know about our blood films, but what I want us to try to get in progress fairly soon is more RDTs. Now we have them in under 5 clinic. I want us to try to find a way to get them back into the ER again. It may not happen till I get back in April, but we're going to try and find a way. And hemoglobin. So if you're working in under 5 clinic, you can get the hemoglobin done very, very quickly. Similarly, if you're in the ER, you desperately need a hemoglobin. You can borrow the machine from under 5 clinic if it's a child. That's perfectly fine. You shouldn't feel like, oh no, I don't have the hemoglobin, so I need to wait and delay things, and run to under 5 clinics, say, I need the HB machine, and just do it. Glucose is really important. Now, something we're not doing, but I want us to do more of, is actually analyzing CSF. So looking at lumbar punctures. The reason for that is, say you have a child who comes in a coma and there is a sort of a vague history. They were sick, they have a temperature, they were lethargic, then they start going into a coma, and then you do your malaria test, they're all negative, they're not responding to our test unit. You first think, oh, they're not really getting better. You're considering meningitis, so we're probably putting them on ceftriaxone. But if we want to have some certainty, doing a lumbar puncture or at least having an analysis of CSF is quite helpful. Now, at the moment, we don't have a good way of analyzing it, but what you can do is, if you do a lumbar puncture, you can actually use a urine dipstick, and you can test protein, and you can test for presence of protein using a urine dipstick. You can test for the presence of blood. You can test for, a rough idea about glucose, and you can even look at it. I mean, a child with a fulminant bacterial meningitis, if you do a lumbar puncture, you will see a very kind of turgid CSF coming out. I've seen it a couple of times, and you know it when you see it, really. And then blood cultures, we're not there yet, but I'm hopeful that in the future we will get to a place where we can start having blood cultures. Maybe we'll have a partnership with Jamali in the future. And then I'm kind of rounding off with the actual treatment of malaria. Why is artesunate better than quinine? Anyone tell me why? Why not just put everyone back on quinine?
Because of hypoglycemia.
Very good, hypoglycemia. Any other reason? There's a few other things.
Maybe the compliance.
Okay, that can be an issue. Yeah, quinine is very bitter. Yep. What else can quinine do to you? Can it do anything to your heart?
I said maybe compliance.
Yep, compliance is one thing. But any other thing that quinine can do? Any other side effects?
Deafness.
Yeah. So tinnitus is one. Hypertension. Hypotension. Good. Yeah, all of those things are true. Now, the other thing we worry about is something called long QT syndrome, which is, it's a cardiac abnormality. So basically, if you give quinine, there is a risk that basically you can cause a cardiac arrest. So the child's heart can actually stop, because what will happen is they'll go into long QT, and then they'll have, that will lead to another arrhythmia, and that's it. So you've got to be really, really careful with quinine. So that's why it's second line, it's kind of down the road. And So that's why, but you're correct. Tinnitus and hypoglycemia are very, very serious concerns as well. Just to say about our test unit, remember, if it first 20 kgs of a child's weight, you want a nice high dose if you're dealing with cerebral malaria, 3 milligrams per kg. And you all know the doses, but just to say, if you have a child who's in a coma, you don't just stop after the third dose, you would continue the R-test-unit QD at least for another 3 days. Million would be your second line if there's no response. Just a very kind of quick overview picture, just like this. These are kind of things that you see in cerebral malaria. Prostration's your commonest one, but the reality is more than one sign at once. So you're usually going to see a child in a coma. There's usually a convulsion. Usually they have some hyperparathyroidism. So just to be aware of that. We don't need to do that. We've already kind of done that one already. But just to talk about the progression as well. So again, with this monitoring, children do eventually start to recover very nicely. And the thing to monitor is their oral intake. So if they're eating and drinking more, then you can begin the kind of follow-on coartem. What I would say is avoid the temptation to add in too many things. So it's very right. Oh, let's put on iron tablets. Let's put multivitamins. Let's put blah, 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 blah. And the problem with that is if you do that too much, then you put on your iron tablets, that will often cause vomiting. And if you're trying to give coartem to a child and they're vomiting because of the iron, you're not going to get any benefit. Multivitamins, they're not very helpful. If you've got a child who is starting to improve their diet and starting to eat and drink as normal, you don't really need that. So just to say, you don't need to be piling on hundreds and hundreds of different tablets. Discharge criteria, really make sure the child is eating and drinking, passing urine well. Definitely make sure they have what I call worsening advice, so they need to know what to do when they go home. So you can't just send a child home and say, oh, go home, and if you get sick, then try to come. You need to tell them, if your child is convulsing or has a fever or something, then you need to come to ER, or you need to come to under 5 clinical. Give them some very specific guidelines of where to go. So it's very important to do that. And then remember, over time, you want to be deworming them as well and making sure you've got follow-up. So we haven't talked a lot about the complications, longer-term complications in the area. But obviously, just to be aware of how dangerous severe malaria is. It is a very high cause of under-5 mortality worldwide. And the important thing really is treating, is attention to detail and monitoring, responding. So every time you do an intervention, whether it's a test or a fluid or an antibiotic or whatever it is, you need to think, well, why are we doing this? How do we best respond? And just looking at those vital signs and responding each time. So we'll stop for questions just there. Any burning thoughts or questions? Put in the chat, or feel free to put your hand up and say things.